Hi, I'm Barbara Harrison. I'm a nurse at Methodist Hospital. I've been a nurse since 1988. Let me tell you, I did 2 years of undergraduate prerequisites at Texas Tech University, and then I went to 2 years at the Health Science Center to get my nursing graduate done, and it was amazing. They do lots of semesters of work in the classroom, and then we got set free into the hospitals, and we got to pick hospitals. We could go to Methodist, or down here we could go to the Wilford Hall or BAMC, a bunch of hospitals, university. Ooh, there's an experience. And I got to see just about everything, and I think it helped to inform me on what I really wanted to do with my life. It was really exciting, scary and exciting, but being able to see in the trauma rooms, in the where the babies were born, getting to see all that made my decision on what I wanted to do. My mom had worked at the hospital where I ended up working right off the bat, and I thought, it's good enough for her, it's good enough for me, and I went over and I started working on the med-surg unit. And I always tell nurses, no matter what, all the nurses, we all argue about it, but I think everybody should start on a medical surgical floor and then go off to where they need to go, because you get to learn to be a real nurse first. And I think that works. That way, everything that you go to do, you've got a real solid base for. I work at Methodist Hospital. I started on the med-surg unit, and then I went to the medical ICU, and then I went to I went to work at the organ bank. I did 3 years at the Texas Organ Sharing Alliance, where I would go and take care of the bodies of the patients that had passed away, like in brain death. And then we waited for the surgeons to come from whatever hospital to retrieve the organs and go put them back into the patients that were on the transplant list. And that was a fantastic job. Let me tell you, I learned more about anatomy in that job, because we literally, when we exposed the organs, you got to really see a full, beating heart, anatomical body, and it was really fascinating. Then I worked a desk job for a while, and did patient placement, and we placed all the patients from all over the place to go to the entire Methodist healthcare system. And I loved that job. I got to go out into the units and see people and talk to the nurses and see what was going on, and then it changed to more of a being on a hotline, and I figured out I missed taking care of patients. So I came back and started working I worked in the recovery room for a little while just to help them out, which was really cool. But then again, they're all still knocked out, so I didn't have anybody to talk to. So then I started working in the apheresis unit, and I looked at all the tubes and wiring that I was going to have to learn and said, oh, I don't think so. But it's an on-the-job training. I'm glad I had all the training I had behind me to do it. I use a machine that's called a cell separator, and there's a couple of versions of them. And anything that we need to either take out blood-wise, treat and put back in, or take out and throw away because it's got a problem with it, or we also have we do stem cell collections for the bone marrow transplants. We do white cell depletions for, hey look, that's Scott texting me. We do white cell depletions for the leukemia patients. We do red cell depletions for the sickle cell anemia patients who, it used to be that they just got treated with pain medicines and fluid. Now we can actually take out those sickled cells and give them back whole blood, and they don't have as many crises. It's pretty exciting. And then we do what's called extracorporeal photo chemotherapy for the people that get the allogeneic stem cell transplants, which means they didn't donate to themselves. They got it from a donor. They sometimes get an over growth of graft versus host disease, and we have to treat those with phototherapy. We take out their white cells put some medicine in there and treat it with UV light, and then put it back into their body to show, to tell the body that it doesn't have to. This is the easiest explanation, to show the body that it doesn't have to react and attack the body so much. It kind of tells those white cells to die back off again. The cell separator, it's all but done under the same format. The centrifuge whips it around with centrifugal force, and it divides the blood out into its layers by weight. So at the top of the centrifuge, there's going to be the plasma level, and that's the lightest one based on weight, and that's where all the antibodies float. So we will take out the plasma layer on patients that have myasthenia gravis, multiple sclerosis, TTP, which is thrombotic thrombocytopenia purpura, and multiple sclerosis, I think I just said. Any of them that are antibody mediated, meaning that the antibodies have gone crazy, and we actually take those out while the medicines are working to help the person feel better. We take out that plasma layer. If it's somebody with a acute leukemia, we take out the second layer, which is the white cell layer. That's the second one by weight. So it's whipping around in this centrifuge, and it's dividing out by weight. So the white cell layer's here. We take that out because when they come in with a leukemia crisis, it is a bigger white cell layer. And I'll try to figure out a way to take a picture of it so I can show Scott and Kathryn what that looks like, because it's pretty impressive, because it looks like you're taking out a big bag of pus. It's pretty gross. But that's to get those physically off of there so they don't stroke out or have any trouble while waiting for the chemotherapy to kick in. And then the next layer down is the red cell layer, which is, so the hemoglobin and the hematocrit, those are all heavier by weight. They sink to the bottom. So whichever layer you need to either remove, treat and put back in, or remove and throw away, it's pretty easy. Once they figured out what to do with the cell separator, it's pretty nifty. I have to know what this is affecting in my body. I have to know all about the blood layers. I have to know what happens in my machines, because if I'm whipping it around there, and let's just say their platelet count is really, really high, it can clog up my machine. So I have to know how to treat that so that I don't clog off the circuit. I have to know all about patients' anatomy and physiology, because I have to know their disease that I'm treating. Because we actually have on a couple of people that we don't remove a bunch of medicines as it's centrifuging these out, but some of the medicines do, and I've had a patient go into a little bit of a crisis because we removed just enough of their medicine that they got worse before they got better. So I have to know all about all of the medical parts of the patient, all about anatomy and physiology. We've had a patient with myasthenia gravis who came in and could not even, they had the droop, they had the eye droop, they couldn't really talk so much to me, they were heavy, and halfway through the treatment, and I've only seen it once, but the other girls have seen it quite a bit, but if you catch it soon enough, you can actually see them start to get better during the treatment. It's pretty nifty, because we're removing those antibodies that are causing the problem with the patient. I just said, we've had it where this person got better right in the middle of their treatment. A lot of those people that have those chronic illnesses, we will set up a regimen where we'll do maybe like 4 in a row or 5 in a row. And then we set it up where you might come in once every 2 weeks or once a month, or everybody gets to their own schedule, which works for them. With myasthenia, it all goes by their ability to, not be physically affected. The eating, a lot of them have a big problem swallowing. That's another part of the thing is I have to know if a person comes in a crisis, I need to know how many days it's been since they've had their last drink or food, because I can drop their blood pressure and cause we've had to kind of semi-code somebody before because they were way drier than we thought they were. We needed to give them fluids during the treatment, and increase the amount of fluids they got throughout the whole treatment so that they didn't get sick and drop their blood pressure. We don't like that. Nurses don't like that. We have a couple of other patients. There's a disease called thrombotic thrombocytopenia purpura, which is TTP from here on out. And it is a thing where basically their body's attacking their cells. They are hemolyzing all of their blood. and it's just another one of those, antibody-mediated diseases where when I take out those antibodies, it brings down that reaction. So we have to do that for usually 5 days in a row or 10 days in a row, and then maybe every other until they start to get better, if it's a true TTP. And it is, they're pretty sick. They don't realize it because they're not really feeling anything like, oh, this or this or this. But they do, all of a sudden they'll notice that they're bruising a little bit, and then some of them will say, ooh, I just don't feel very good. And then they get to the hospital, and they have no platelets left, which are the ones that make the blood clots. Those are the ones that help you clot when you, cut yourself. You have no platelets left, so that's why they start getting that little petechiae. And their H&H, their hemoglobin and hematocrit is usually a little bit lower by then. They have a bunch of they have haptoglobin, they have, their LDH is way off, and it's because the body is hemolyzing these, and then it's kind of, their body is reacting to this and getting really, really sick. So after about 10 treatments or 5 treatments, everybody's different, depends on how long they've been putting up with us. We had a teacher who just kind of figured she just was run down from being a teacher, and it took us a while to get her back in shape because she had been doing this for a long time. Okay, what kind of illnesses do you... Well, okay, I just told you all those illnesses. When we do the ones where we take it out for the stem cell transplants, that's a patient that they've decided they can donate to themselves. It's safe for them to donate to themselves, and they're usually put into remission first with chemo, and then they come to us. We separate their blood. I pull out their... They've been given shots for 4 days in a row, and... they get Granix or Neupogen, and it stimulates their bone marrow to make these stem cells, and we give them Mozobil, sometimes it's a new drug, to force those out into the bloodstream, and I basically pull them out with my machine, and then we put them in a bag. It gets treated at the cryotherapy lab, and then it goes and gets dripped into them like just getting some blood or something, or an antibiotic, and then that hopefully changes them back to not having their whatever their leukemia, lymphoma, multiple myeloma, all of the blood cancers. And then like I said, with the, anyway, so they take those out, the cryotherapy lab treats them, then they get full body chemo. And so I know they've already gotten a lot of chemo, so I have to be, as far as, how sick are they, what do I have to do with them? We have to just be very careful with them, because sometimes they get a little bit depleted on the machines. So I have to use all of my nursing, all of my biology, all of my physiology to make sure that I'm taking care of these people. The red cell exchange, the people come in, they're hurting, they're on a ton of narcotics, they're not doing well. Most people think that they're drug seeking, but if we come in and we can remove that entire red cell layer and give them fresh red blood cells, they have a better chance of not getting into crisis so often. It's kind of cool to watch them get better. Well, sure, I will talk about anything. um, I don't know about everybody else, but I didn't really know what I wanted to be in the beginning, and it was kind of confusing for me. So, but everything I learned, no matter if I thought I was going to change to something else, I thought I was going to do physical therapy, I thought all of that basic stuff. Do you remember everybody said, oh, I'll never use algebra again? I don't know that I've actually used a ton of algebra, but I've used a ton of, weird math. And I think I got it all from, being high school math and my undergraduate stuff. So, I want to say I paid attention all the time, but as my niece and nephew know, I was a bit of a, I kind of had fun in college before I moved on to really being serious. But pay attention. All of that stuff that you learn, even if it's something you never actually in your mind say, oh, I used it. No, it's all part of that whole big picture. So pay attention. Have a little fun. Because once you're out in the real world, you can still do continuing ed and all that stuff, but it's never the exact same. It's never the exact same thing as when you're in college and getting to be just that super student. Unless, of course, you go on and be a professional student and do your master's and your PhD. But pay attention. All of that stuff really will. Ask questions. Write it down, because I know I've actually gone back to my college books and looked at stuff and seen the difference, like some of the changes that have come up. But but most of those basics, they are tried and true. The body is the body. We've just come in a long way for treating it. This didn't used to be done 20 years ago. They knew how to just separate the cells like in the lab, but they didn't know what to do with all of the parts and pieces. So just pay attention. Soak it all in and have a good time. but you will. It'll especially in the anatomy and physiology. Whew, if you know the basics, all the rest is built upon and just absolute cake. So I think that's it. And I think I've been looking at the wrong side of the screen this entire time, so just ignore that. And I can say I've been sick, so that's why maybe I don't know what I'm doing on video. So thanks, guys. Love you, Scott and Kathryn. Hello, whoever else is watching this. And good luck in school. Have fun. Bye.
So this is the HELP LDL apheresis treatment. And we start with a blood withdrawal site. We have to access one vein to withdraw the blood from the patient to the machine, which is the Futura Bibron machine. And then we also have to have a return site. So the blood returns to the patient through the return site. And all of this is continuous. There's no one point when there's too much volume depletion, because it's called an extracorporeal treatment, where the blood is continuously circulating to the patient, circulating out and circulating back. So this is the Bibron Futura machine. It's an apheresis, and particularly a selective LDL apheresis machine, but we know that the filter will precipitate many other factors, particularly inflammatory factors, some cytotoxins, and there's among some other things that will be removed with the filter. So this is how it works. When we start, we circulate the patient's blood to the blood pump and the blood chamber, which is just a holding chamber releasing air. There are several chambers that collect air, so you never have to worry about air embolisms. But there's also a safety feature here at the end, which I'll explain in a minute. Blood comes and circulates into the plasma filter. And this is a plasma filter that separates the red blood cells from the plasma, because it's the plasma that we treat. So red blood cells exit out here and are held in this chamber here, the venous chamber. But concurrently, all very rapidly, the plasma is exiting out here and going through a blood leak detector, then circulating up here. And maybe you can focus in on that. That's the plasma buffer pump. Right here, the patient's plasma joins another fluid, which is brought up from down here. This is an acetate buffer solution. And what it is, it's a special solution that we have to put a lot of heparin in, 300,000 units of heparin, because this pH of this solution is 4.85. And when we add this extra heparin to it, it changes the pH to 5.12. And at 5.12, those molecules, they become more positively charged, and they bind naturally to the negatively charged heparin, which causes a precipitate. And the precipitate is when, that's what we want. We want the binding of these elements that we're trying to remove from the plasma. So then this precipitate starts to occur in here. As you can see, it starts to turn a yellow, milky color. That's already precipitation occurring with the plasma. And then we want to remove that precipitate, because that's all the gunk we're trying to get out. Inflammatory factors, lipids, fibrinogen, lots of other elements are being removed. That precipitate circulates down here into the precipitate filter. This is all some extra sediment. This is a very interesting looking filter. A lot is happening here. A lot is being removed. But the precipitate goes into the filter, and in the inside the cylinder of this filter is where the precipitate remains. And then the clean plasma exits out the top. And as you can see, here's the clean plasma. But now we still have to remove all the extra heparin that was used for the precipitate. So then the clean plasma that's precipitate free needs to go into this filter. This is called a heparin adsorber. And the heparin adsorber helps to absorb all that extra heparin so it doesn't go back to the patient, because that's only used for the precipitate, for the purpose of precipitating. Then the clean-free plasma, precipitate-free, heparin-free, goes into the dialyzer, and the dialyzer just finally rebalances the patient's plasma back to a normal pH level and removes any extra fluid. And then that clean plasma from the patient now circulates back up here into this venous chamber, remixes with the red blood cells, and finally returns back to the patient. But all of this is happening very rapidly. So it's, but that's the process explained in a slow motion.